Please listen carefully.
Hello and welcome to GasGasGas, the podcast that covers the FRCA primary exam. We're going to fit into your day and give you as much of your life back as you could possibly imagine. I'm here to make your studying easier. Listen to us on your commute, in the gym, in the shower, or when you're ironing your scrubs. Expect facts, concepts, model answers and the odd tangent. Check out the show notes for all the detail and remember to follow the show so that you never miss an episode. Let's get on with it. So Tom, this is your pharmacology station. We're going to cover Adrenoceptors, local anaesthetics and the Vaughan-Williams Anti-arrythmic classification. Are you ready?
Talk me through the structure and function of adrenoceptors.
Adrenoceptors are G-protein coupled transmembrane proteins that respond to endogenous catecholamines, so adrenaline and noradrenaline. I can't recall the number of subunits at the moment, but the function of them is multiple across different tissues. So importantly, we have effects on the heart, effects on the peripheral vasculature, and effects on other areas of smooth muscle, including within the respiratory system. So the number of beta-1 receptors is relatively high in the heart, and so it has important effects on the cardiovascular system. So in the presence of adrenaline, beta-1 agonism causes increased heart rate, it causes increased stroke volume, and therefore increases cardiac output via those two mechanisms. On the peripheral vasculature, we have alpha adrenoceptors, alpha-1 specifically, which in response to adrenaline and noradrenaline cause vasoconstriction, and most commonly to maintain blood pressure. And in respiratory smooth muscle, we have beta-2 receptors, which cause relaxation of the smooth muscle in the small airways, which is why we use beta-2 agonists in asthma and COPD. There are also alpha-2 receptors. These are most commonly present at the presynaptic membrane as a negative feedback loop, particularly within the central nervous system. So alpha-2 agonists have a few interesting effects. They cause sedation to some extent, and they're used for that commonly in intensive care. And they cause hypotension, although because they're working on that feedback mechanism and there's some cross-reactivity, they can cause transient hypertension when they're first administered. So I think I've talked about beta-1, beta-2, alpha-1 and alpha-2 there. There are some other effects on peripheral tissues which are less important.
Such as?
So there are alpha receptors present in the smooth muscle of I believe in the neck of the bladder, which can cause increased muscle tone there. And so in patients with obstructive urinary symptoms, alpha agonists can alleviate those symptoms.
Okay. And for extra points, beta-3 receptors?
Beta-3 receptors are, I believe, present within the pancreas, and they lead to alterations in glucose metabolism, but I can't remember more detail than that at this point. What we do see when adrenaline in particular is administered is a rise in lactate, and I believe that's from increased lipolysis, and I think beta-3 receptors are important in that process.
Ah, nice one. So you mentioned a few drugs that have influences on these receptors. Have you come across any other agents that can bind to beta receptors, alpha receptors? I think you mentioned salbutamol, adrenaline and noradrenaline.
Just to be crystal clear on the question, are you asking about drugs that can have an effect on those receptors or drugs that interact directly with the receptor?
Both, my good man. So could you compare and classify agents which have an influence on the adrenergic receptors of the human body?
So we've spoken about direct effects of adrenaline and noradrenaline and the various receptors in the body. In anaesthetic use, we also have a couple of other agents that are commonly used to support blood pressure by causing vasoconstriction, namely metronidazole and epinephrine. Metronidazole and ephedrine, as well as phenylephrine. Phenylephrine is direct alpha-1 agonist that causes peripheral vasoconstriction. Metaraminol causes endogenous release of norepinephrine, which causes fairly pure alpha-1 agonism and therefore peripheral vasoconstriction. It also has some beta-1 activity as well. It also has some direct alpha-1 agonism itself as well. Ephedrine also works in a similar way but causes adrenaline release rather than noradrenaline, so it causes increased heart rate and increased stroke volume as well. Because of this mechanism of causing endogenous release of catecholamines, both of these suffer from tachyphylaxis, so their efficacy reduces with use over time. There are also other agents used in intensive care and in the critical ill patients more commonly, such as vasopressin, butamine, dopamine. The butamine itself has significant effects on stroke volume, particularly at lower concentrations. At high concentrations has a chronotropic effect as well, so a positive chronotropic effect, so it increases heart rate at high concentrations. And it also causes some peripheral vasodilatation, so sometimes called an inodilator, and is sometimes favoured in patients with heart failure and cardiogenic shock. Dopamine also has some effects on beta receptors, including beta-1 receptors and alpha-1 receptors. Yeah, I can't recall the details at this point actually about dopamine.
I think you've been doing well to get there, Tom. So, moving on to a different but very commonly used set of drugs in anaesthetic practice. What local anaesthetic agents do you know of, and how do they exert their effect?
So, local anaesthetic agents can be broadly classified into esters and amide due to their chemical structure. Amide anaesthetics are most commonly used in clinical practice, and I will list the more commonly used esters because it's a short list. So procaine is an ester anaesthetic, as is cocaine, and amide anaesthetics include ropivacaine, bupivacaine, levobupivacaine, prilocaine. Was the second part of the question, how do they exert their effects?
Yes.
So anaesthetic agents work by sodium channel blockade from inside of neurons, which is an important point in terms of their pharmacological action. In order to enter the cell, they have to be present in a non-ionized form so that they can freely pass through cell walls as small non-ionic molecules. And then once within neuronal cells, they block sodium channels, preventing hyperpolarization of cell membranes and therefore blocking decremental conduction of action potentials. This aspect of their function, so needing to be non-ionized to pass into cells, can affect our choice of local anaesthetics. So anaesthetics have different pKa's, which essentially is a number index to tell you what portion of the local anaesthetic will be ionized at a given pH. So those that are more highly ionized will have a slower onset of action.
Could you compare the pKa's of some of the commonly used local anaesthetic drugs?
So lidocaine, let me just think about this for a moment. So lidocaine has a fast onset of action due to the fact that it is unionized in very high proportion at pH of around 7.35 physiological pH. Its pKa is significantly, let me pause and just backtrack slightly. I'm just thinking through pKa's and how they compare to physiological pH. So lidocaine has a higher pKa than 7.35. I don't recall the exact pH currently, but it means that it's unionized in around 25% at physiological pH. Bupivacaine has much higher pKa lidocaine, meaning that a much smaller proportion is unionized at body pH, leading to a slower onset time, which is something we're familiar with from clinical practice between lidocaine and bupivacaine.
Is there any way you can alter their onset dynamics?
Yes, so onset dynamics can be altered by manipulating the pH when they're administered. So before the solution you inject has chance to equilibrate with surrounding tissues or blood, it may still have time for unionized forms to pass into nerve cells if the mixture you've injected has its pH altered. The most common way to do this is by adding bicarbonate to local anaesthetic mixtures to decrease that onset time.
Okay, lovely. So you mentioned that they block sodium channels, and obviously in nerves as we use them, but what other sodium channels are blocked by local anaesthetic agents?
They also block sodium channels within the nerve conduction system in the heart, and so can be used as anti-arrhythmics as well. So, for instance, lidocaine itself can be used in VF in an arrest situation as an alternative to amiodarone, and is classed as a Vaughan-Williams 1B anti-arrhythmic agent, I believe.
Yes, and that delightfully brings us to the Vaughan-Williams classification of anti-arrhythmic agents. You mentioned lidocaine as a 1B. Talk me through the other classes, please.
So the Vaughan-Williams classification system can be broadly divided into 1, 2 and 3, and then the subdivisions class 1. So class 1 agents, 1, 2, 3 and 4, rather than 1, 2 and 3. So the class 1 agents are sodium channel blocking agents. The class 2 agents, beta blockers. Class 3 are potassium channel blockers, such as sotalol and amiodarone. And class 4 include rate-limiting calcium channel blockers, such as diltiazem and verapamil.
Excellent. If this was a physiology question, we might start talking about... I don't know if... Is it fair game to ask you about how it influences the action potential in a pharmacology question? Probably.
In a pharmacology question, I think that is fair game. I'd say you're not going to get much mileage out of me on that, though. from a practical point of view for the podcast. I would break down at that point. I've already forgotten the classification system. So.
Well, you've just relearnt it there, Tom.
Should we pause and I'll just try and give another boxed answer of the classification system? A, to help me learn. B, for editing purposes. C, so I can actually try and give examples from each as well.
Yeah, so I'll just tell you it so that it's fresh in your brain. Class 1, sodium channel blockade, but remember there are subclasses of that, A, B and C, which is probably where the extra points are. A, prolongs the action potential. B, shortens the action potential. And C, doesn't do anything to the action potential. A, quinine. B, lidocaine. C, flecainide. Yeah, quinine, lidocaine, flecainide.
Just remember quiff.
2 is beta, like you said. Metoprolol, atenolol, esmolol, bisoprolol, all the lols. 3, potassium channel blockade, prolonging the action potential.
Amiodarone's the most obvious one, isn't it?
Just go in with amiodarone. Yeah, don't worry about sotalol. And then 4, calcium channel blockade, and that slows the influx of calcium at phase 2. So it's going to prolong your action potential, isn't it? Because it blocks the influx of calcium, so it takes longer.
Yeah, if it slows any phase of it, then it has to prolong the length of the action potential. Do any of them reference refractory period? I know they have effects, but does the classification system reference the refractory period?
Not on this little box I've got here.
No, we'll go with whatever little box. They're not going to want as much detail as, it's got my brain ticking now, but
Yeah.
Don't say too much is another thing I'm starting to learn.
Yeah, don't get carried away. So, talk me through the Vaughan-Williams classification system.
So, the Vaughan-Williams classification system of anti-arrhythmic agents is a system that classifies those agents by their mechanism and by their effect on the action potential within the cardiac conduction system. So, we have classes 1 to 4. Class 1 are sodium channel blocking agents, divided into class 1A, B and C. In class A, we have agents that prolong the action potential. In class B, we have agents that shorten the action potential, and class C are agents that don't make any difference to the action potential. So A, B and C, example of A would be quinine, B would be lidocaine, and from C we have agents such as flecainide. In class 2 of the Vaughan-Williams classification system, we have our beta-blocking agents such as metoprolol, labetalol, bisoprolol, that reduce heart rate. In class 3, we have potassium channel blocking agents, and in class 4 we have calcium channel blocking agents, specifically rate limiting agents such as diltiazem and verapamil.
Lovely. And those last two classes, 3 and 4, what sort of influence on the action potential do they have?
So class 3 prolongs the action potential within the cardiac conduction system, and class 4 also prolongs the action potential by slowing influx of calcium into the cells.
Yeah, I think if it's worth just being able to draw that action potential diagram, Tom, I reckon. You might, if you're in the exam, you might be tempted to do it, and it might help you tie it together a bit.
It's one of the things that's kind of on my list, because I've found it confusing in the past, though. You know, when you just make judgments about which things are going to take more time, I've put it a bit lower down because I've learned it before and then I get muddled with it, and so it's a bit of a gamble. I'm going to refresh it and try and I think it's useful to be able to demonstrate all of those agents with reference to the conduction system.
They love it as a question, I think, even though its actual use in clinical practice is sparse. Just a nice way to classify them all, and that's what they like.
When you're looking at a patient, thinking about the action potentials of cardiac myocytes and specialised conduction cells is never, ever going to clarify the situation for you. It's just going to confuse you.
I think the answer is always give amiodarone as well, but you know.
No. Shot.
Okay, so just generally there, Tom, it sounds like you're a bit less happy with pharmacology compared to physics, but still picked up all the main marks. It's probably worth having another look through the structure and function of adrenoceptors, because that's like low-hanging fruit.
Adrenoceptors and GABA receptors, and also types of anti-epileptic agent and their mechanism. I've got a short list of things that I already know I need to learn.
Yeah. But for the sake of this, it's a G protein coupled receptor with 7 transmembrane domains, with 3 subunits that go off and have different activities depending on the nature of the adrenoceptor. So there's a GI, a GS, and a GQ subunit, which all have differing downstream effects on either adenyl cyclase or phosphodiesterase, which yield alterations in either the smooth muscle or, in the context of cardiac tissue, may alter inotropy or chronotropy.
Yeah. And the GI, GS, and GQ. So GI is inhibitory, isn't it? The I stands for inhibitory, I think, doesn't it? What do the GS and GQ stand for again?
GS is stimulating.
That's
so
it. Yeah.
They both either up or down regulate adenyl cyclase, and GQ alters
and modulates phospholipase C, which cleaves PIP2 into DAG and IP3. PIP2, IP3, and DAG. We talk about more of them in the show notes. Go and check it out. I will see you again shortly for another VivaCast episode where I ask Tom, what is oxygen? Have a think about what you might say. Cheerio! Thanks for listening to that episode, guys. If you found it useful or awful, please like and subscribe and rate the show. Definitely go check out those show notes on GasGasGas.uk. We all know that this is a bucket of content. I want you to take some time for yourself and don't overcook it. Don't freak out. Keep studying.